Morning. Yes, I have two cases, and the first one which I have today is uh, I'm presenting 28-year-old female who has been diagnosed with sickle cell disease in her childhood, who has been a patient of Dr. Clayton Davis in a small town close to us at Silicaga, and also following Dr. Robert Avery at Montgomery Cancer Center, who has been admitted multiple times to our Baptist facility for sickle cell pain crisis, comes in with bilateral lower extremity pain on 4/8/2023. Um, she reported uh, bilateral lower extremity pain. She came in to the night float team and she said the pain was 8 out of 10 in severity and received one larger dose of Dilaudid. Uh, in the ER admission, about 2 milligrams, and then was given to us for the care. When we encountered the patient was a little drowsy, so could not get much history, but on the following day she didn't she mentioned that this pain had been going on for the last few weeks. Her pain was not relieved with any home medications. She was on Percocet 10 by her primary hematologist, and she also mentioned that she never had any fever or any chills or dysuria, but she had been sexually active and noticed some discharge. uh, However, she is very soft spoken and a poor historian. With among the past medical history, she was also noted to have some substance use disorder and had been treated in one of our addiction outpatient clinic. Uh, she's a known case of sickle cell disease, has been admitted in past with norfentanyl overdose, and also has known case of hypertension, known case of uh, genital herpes, and also uh, uh, among recent procedures in 2014, she had C-section done, she had cholecystectomy done, and dilatation and curettage done. This was in 2010. Um, Among her home medication, she was on, as per patient's description, she was on Percocet 10, hydroxyurea 500, and folic acid 1 milligram. We did not see any refills of hydroxyurea and folic acid in the last 6 months. However, there was a repeated prescription of Percocet 10 that she had been taking. Uh, she was also on noted to be supposed to be on Zoloft 50 milligram, which she had not been on for about a year. Uh, and when she came in, her vitals, the maximum recorded temperature was 98.5, and her heart rate was in 110, and her blood pressure was about 132/67. And she was saturating fine on room air with a respiratory rate around 18. Um, Among pertinent physical examination, I saw some joint tenderness at the hip joint as well as the knee joint and ankle joints. Uh, no other complaints, no swelling, no redness. Among the pertinent labs that we had, her WBC count had been elevated to around her 12.9, which her usual stays in 8. And her hemoglobin, however, was in the normal ranges where her baseline is 10.5 and we had it at 11, and hematocrit is 31.2. And her retic count had been around 3.55. And she was noted to be a hemoglobin sickle cell SS variant. However, we did not have any recent hemoglobin electrophoresis. I waited for the records from hematologists, but unfortunately the records sent by them also does not have the titers. Among the other significant labs, we had a total bilirubin of 1.9, and her creatinine was at the baseline of 0.7. Her urine analysis was positive for benzos and opiates. And looking for the sources of infection and complaining of discharge, we also scanned for the STI panel, and she was found out to be positive for Trichomonas. She had a clear chest X-ray, and she had a recent CT during the last admission in January with us, and she had some osseous changes noted during that admission. Noting all of this, the night team had considered this a sickle cell crisis, and they started the patient on uh, low dose of dilaudid PRN 0.5, and for severe pain, and for moderate pain about 0.25, with a breakthrough of uh, zero point 0.1. And following this, she was also started on D5 half NS at 75 cc per hour. We resumed her hydroxyurea, and we resumed her folic acid. And till then, we early morning we consulted the pain pump, uh, uh, trying to set up the pain pump with the anesthesia specialist. However, it took us a time to get her to the pain pump, and she was on Dilaudid for the remaining period of time. And she would not respond much to anything, and she would be sedated the most of the days. And she would get up to ask for pain medicine and then go back to sleep. We saw the trend in her hemoglobin. We saw the trend in her hemoglobin being stable so far, and even her WBC count started coming down when we started treating her trichomonas with metronidazole. And on day 3 of her admission, we finally got her on pain pump. That was on 11th of April around afternoon. And soon after she went on to pain pump, she responded about 3 hours on remaining on pain pump. We gave her 1 milligram of loading dose of Dilaudid so that she can tolerate that well. She was little reluctant to go on it, but then she responded. After 3 hours of that, she decided to sign AMA and leave the facility. On further, we received some of the records from the addiction clinic, and we also received some records from the primary hematologist. She had been repeatedly following her hematologist, where she had been getting her prescriptions of Percocet, but there was a concern that she has a polysubstance use history in past, and that's why the hematologist was trying to get her to the addiction clinic. She had visited the addiction clinic back in December, where that was her last visit, and she had requested she was requested to get inpatient withdrawal treatment for opioids, and she would not go for an inpatient admission to multiple facilities after being referred. And her being the last, there was some discussion about the correction facility needing her records for her court visits, and she was denied by her addiction center, and it appears that the addiction center was close to firing her. So unfortunately,
quite a lot to unpack.
Sorry?
I said that's a lot to unpack.
Yes.
All right. So so a couple of things. So in this scenario, one of the biggest things or problems that we see is we're not helping someone by giving them opioids, right? And so reaching out to her primary hematologist is going to be key, or whoever is continuing to give her pain medicine, and insist that they stop, because otherwise she has no motivation to go seek additional, assistance with her addiction. She's getting what she needs. So there's no reason for her to want to go. And Percocet, as we've kind of talked about, oxycodone seems to be the worst offender. And from what you've told us, she's pretty scary, right? She's overdosed already on norfentanyl, meaning that she's using street drugs. She came in with benzos, not prescribed. So she's pretty scary.
Yes.
So I would reach out to her outside team, her primary hematologist, and say, we've talked about this and we're really worried about this woman, and we don't want to play a role in her demise, right? That's the one thing we can do, is we don't have to be part of their demise. And so we need you to stop giving her Percocet so that she will seek care, or that we can help direct her to care. And, obviously she is someone who would want to put on Suboxone, but we'd have to understand too what her barriers have been. Does she not want to be inpatient because she has kids at home? And so she doesn't want to be on an inpatient addiction stay because she can't afford to leave home. Does she work? Like, what are the other barriers in this case?
Right. So far, I saw the notes of the addiction clinic, and I also found that they were trying her on Suboxone, but they were also concerned with her multiple substance use. So they said it would be better to continue monitoring her inpatient. Among her barriers, she has two kids, one 5 and one 2, and she's a single mother. So that could have been a possible barrier.
Yeah, so that's usually why we find people don't want to be inpatient. And so we try to adjust and treat them outpatient as much as possible. The other thing that we found is in these scenarios is often if they're treated by addiction without pain, they're not getting enough Suboxone. We use a little bit more than your average sort of addiction treatment. And then of course, we're not treating her sickle cell disease. So another important point, don't start somebody on hydroxyurea, please, if they're not taking it at home. You're going to cause pancytopenia, and then you're not going to know why you caused bone marrow suppression and pancytopenia. So never, if you can see that they're not feeling it, there's no need for you to do that.
Mhm.
I am curious. You mentioned that she has hemoglobin SS disease, but her labs don't necessarily show that. So I'd be interested to see an electrophoresis. I would guess she actually has SC or S beta plus disease. That'd be my guess. Most people with SS, not all, are not walking around with a hemoglobin of 11. And so I would definitely want to see that just to help us further manage her. But this is somebody who's going to be very resistant to wanting any help because she's getting what she wants. I mean, this is clearly a case of addiction with opiate use disorder. And obviously these kids are in real trouble that are her children.
Right.
Do we know if she has other support systems?
So she has a boyfriend which she lives with, but I was pretty not sure because her family we tried to reach, they did not respond. And she used to live, like on her older records, the outpatient clinic at her hematologist says that she used to live with the family, but right now she's living on herself. And we were not sure whether it was on streets or with her boyfriend, but definitely wherever she was getting the access to substances that were not legal.
And I assume someone has reported her in terms of to DHR, given all of this and her multi-substance abuse and overdose history.
Yes, doctor.
I just wanted to make sure those kids were, at least somebody was aware that they're obviously in a bit of an unsafe living environment.
Yes, doctor.
So it sounds like in terms of management, the only thing I would have really suggested is not giving her hydroxyurea. And other than that, getting her on the PCA was the right thing to do. The fact that she left so quickly tells you, unfortunately, a lot of what you need to know. And this is a scenario in which someone is not getting pain medicine for the right reason. So sounds like you did everything right. And the only thing I would try to do is reach out to her hematologist, and I'm happy to speak to them as well if they're willing. But us giving anybody with opiate use disorder or addiction more pain medicine is going to make it so that they don't want care, right? They think they're getting everything they need. And unfortunately, we have seen in some of our young kids, we've caused this problem, right? We've been giving people opioids for a long time for their sickle cell. And so explaining that we rarely use the word addiction. We really focus on opiate use disorder and opiate dependence and things that of that nature to say, look, we've caused this problem. Now we need to help treat it. And those are ways we would go about it. But giving her more Percocet is not going to help her.
Right.
So that's a tough case. I unfortunately expect that you will see her again.
In case if we do, we'll try to explain all of this again, because we tried on this admission, but she was very reluctant.
Oh, I'm sure that she's very reluctant again, but we're explaining things while giving IV Dilaudid. Right. So we're not helping is the problem.
Right.
And so it's we'll make sure we get one of our rounds. We'll have Pat come talk. He's the psychiatrist that has taught me everything I know about this kind of situation. So we'll have him come talk, and he'll talk for an hour, but he gives an amazing discussion on that. Unfortunately, all we do is feed the problem if we're feeding the problem. And until we stop that, we're not gonna get anywhere. But important questions always when you see moms of young kids who are single parents is always to make sure you ask who has your kids right now and are they safe?
Right.
So that's just something else that we always want to make sure of, is that we're not leaving the, we don't have a parent in a hospital where a young kid is at risk. And this is somebody who may need inpatient detox, that there are ways to even facilitate that without necessarily having addiction on board, but it's certainly a challenge. And certainly treating her sickle cell and her addiction together are going to be hard to do in your hospital. So this is someone I would exchange and then try to keep to get them onto appropriate therapy. The other thing, however, is in almost everybody who has decided they don't want to take Suboxone, it's because they're still taking opiates, and the two will counter each other in some capacity or make them sick. And so if you're still taking Percocet and trying Suboxone, then nothing's going to work. And that may be something else that happened to her.
Right.
Any questions?
Julie, this is Jewel. Can you hear me?
Yes.
Yeah, so I was attending on this one. Thanks for reinforcing my hydroxyurea comment on hospital day one. He was very generous. She was probably living on the streets. And the reason that it took so long to get the pump set up was every time anesthesia came to consent her, she would be asleep and would not wake up and would not respond. So I, as the attending, said, well, that's just really, really difficult. So she doesn't get any pain medicine until she consents. So it took us into day 2 for me to say, wait, hold on, just stop giving her pain meds. And so we did, and then she consented, and then she left. So, I mean, I just, I'm a little bit mean sometimes, but I think we have to do that. Is if we have a treatment that we want to start and the patients aren't agreeable, then we don't do what they want us to do, because, she clearly had fentanyl and other things going on. So, we very early on suspected what the situation was. So I'm just pointing that out to my residents, is we don't have to give them pain medicine if they won't consent to the pain pump.
It's interesting that you require consent.
I can't control anesthesia here. Years ago, they wouldn't do pain pumps on the floor. So, hey, look at us. Yay.
That's just very, that would be a conversation we should start to facilitate.
I wonder if it's just, it's not like a post-op they use them, but they've already consented them for anesthesia. So I don't know.
I guess, we're not giving them anesthesia through a PCA pump.
Right. I can't explain anesthesia's protocols.
Yeah. So if you wouldn't mind at some point connecting me to them.
Okay.
I'd be happy to talk to them about that, but that's certainly impairing care that you're trying to provide. I mean, but that, obviously everything about this situation is hard. And what you did was the right thing. Again, it's not that we're not trying to treat pain, it's that we're trying to treat it in a safe way, especially if someone may have other meds on board. The other thing that we have unfortunately had to do in some situations is make sure they don't have other drugs in the room. Because we've had a few patients, and this actually, thankfully not at UAB, but my friends at Duke actually had 2 deaths in the hospital from patients with drugs they brought in, because what they were there for was an IV. So something to be wary of. I hate to say that because it casts a light that we don't necessarily want on our patient population. But I would say anybody who's got multiple types of, no matter what they're in the hospital for, if there's someone who is clearly a multi-substance user, be wary of what they have in the room, because you just don't want to facilitate their demise. I had my own personal bad experiences with, we had a couple of patients who would crush oral Benadryl, or they would wait for a nurse to bring them their oxycodone and crush it and shoot it. And it never ended well. So just some things to think about, but it sounds like you guys did everything you could. And we will certainly be happy to reach out to the patient. Doesn't sound like she's going to have any interest in getting the help that she needs at this time. And again, until whoever her hematologist is stops giving her Percocet, she doesn't have a reason to need help. So that's going to be key in helping her.
I'll definitely text our hematologist. He is very helpful and responsive to us, Dr. Avery. So I'll tell him about this.
And I'm happy to talk to him. I mean, I think there are some people, and I find this more in our community physicians, community hematologists than our sickle cell centers, who feel like that they're not treating someone or being ethical if they're not giving opioids. And in fact, that's not really the right answer. There are a lot of other things we do for sickle cell disease. So I'm happy to help him if he's interested in talking. All right.
Thank you,
Well,
Dr. Kanter.
case number 2.
Yeah, case number 2. I think I had a detailed discussion about this case with you. So this, surprisingly, the patient got transferred and admitted in the same bed which this patient left, the same room, and we already had the pain pump waiting there just to be connected. But same again, this is 30-year-old Mr. Ladurius Jackson. He is a established clinic patient with us. Last seen by us in October in our clinic, and also he has been a regular touch with UAV Birmingham team with you, Dr. Kanter. He is a known case of sickle cell disease, diagnosed as a child, and currently been having a sickle cell crisis and been admitted with us in past, the last admission being in January, and had about 3 admissions in the prior year. He came into our setup with the complaints of, again, extremity joint pain, chest pain, and said he appeared to be in a sickle cell crisis and was going on through the sickle cell pain. He described his pain 8 out of 10 in severity. He said his baseline is usually 5 out of 10, and he responds and works well with that. When he came in again, ER gave him a dose of Dilaudid and was transferred to us in our care. And we started him on a low dose Dilaudid at night, again 0.5 milligram for severe pain, Q8 hourly, and 0.25 Q6 hourly for moderate pain, with the breakthrough as 0.2. And with this, we also started him on fluids. And following this, the next day, when we encountered the patient in our service, we reached out to you early morning after our rounds, and we found out that the patient was supposed to be on a Suboxone therapy. However, when we discontinued the patient's Dilaudid and we tried to get him back on Suboxone, patient had strong resistance to it and refused our care. After that, on a detailed discussion, we gave him an option. He explained that after the first dose of Suboxone IV, about 2 weeks ago, he had thrown up at home and he had been constantly vomiting, and ondansetron did not help. We tried to explain him that we would like to monitor you inpatient with the Suboxone, but he was very reluctant to it. However, he said that he tolerated methadone well to us. And we tried to initiate methadone, but he was still hesitant in continuing the care with methadone and NSAID for pain management, and decided to leave AMA the very next day. With him not having much options with us, we still gave him some NSAIDs and still helped him for pain if he wishes for. And we asked him to reach back to you, and him showing strong reluctance, we could not get him to comply to what we wanted. But same thing in 2 days happened, and I'm so sorry, my presentation is a little weird because my computer stopped opening the chart and helping me where I had saved the notes.
No, that is no problem. So yes, we had been working with him for days, actually, weeks, felt like. And we're not so sure about this true vomiting because we actually never saw him vomit every time that we gave him medicine. We were worried as well that he is someone who was still taking some home medicine, which of course wasn't helping. So we worked on several doses that were unsuccessful. And then he came in the most recent time before you saw him. He had come to clinic on Monday with acute pain, and also hadn't taken any of his home Suboxone since Friday. And we gave him IV Suboxone or IV buprenorphine, and actually he got significantly better. His pain went down, he looked much better, he felt much better. But he didn't want to continue it because it's not what he wanted. And so it wasn't that he didn't tolerate it despite, and we also had lots of advice in terms of Zofran and Phenergan. But unfortunately, he was not ever consistent with actually trying this plan. And interestingly, he told you methadone, he had no problems with methadone, except that he told us he vomited methadone all the time as well. So I'm not sure that he's reliable. We've actually never seen him vomit once. But he really does worry us quite a bit. I believe he has since restarted methadone at home. I think that's where we are at the moment. But you did absolutely the right thing. You've in both patients, right? Neither of them were in danger. Neither of them were hypoxic or a risk to themselves or anything else. So you're not treating them by not following their exact requests for pain medicine. And I think that that's really important to recognize. You're offering them multiple other options. And the only thing I would say is whether they really should be technically leaving AMA or they can just leave. If their pain's not bad enough, they can just say, I want to be discharged. And that's okay too. Because again, there's no reason, recognizing that vaso-occlusive crisis is a diagnosis by the patient, right? They say, I'm in pain and I'm having a crisis.
Right.
That they can say, my pain is not enough that I feel like I need to stay here. Right. Which is essentially what they're saying. And so you don't need to necessarily require AMA. You can say it's fine to just self-discharge. There's nothing, you're not febrile, there's nothing you're at risk of in terms of that. So I don't think you should feel like they have to be told they're leaving AMA. They should sort of brought themselves in, they can bring themselves out.
Right.
Yes, in Mr. LJ's case, we're continuing to work with him. And, the difference with him is that he is chronically transfused. And so we also know that he has some protection in place to really prevent some of the bad outcomes. And we really want him to do well. So we are trying very hard to work with him on getting this chronic pain under control and to help his understanding that taking Norco or oxycodone or everything else every 4 hours is just not a way to go about life.
Right.
So we are all working on that with him. And I think the more that we continue to speak with the same voice, that he will come around.
Right. Dr. Kanter, my question with both these cases was any patient who has been on a Suboxone therapy and has been on we are trying to manage his opioid pain medication addiction. How do we identify this patient would be in genuine crisis and we make sure that we are not missing it?
So you have to remember again, and this is the hard part, right? There's nothing you can do to diagnose their crisis, not really. If they say they're in pain and having a crisis, you, for the most part, have to take their word for it. Now, one thing that's helpful is to say, how long has this been going on? A patient, they'll say, oh, it's been going on for 3 months. A crisis doesn't go on for 3 months. It's actually not physically possible. So getting the history of how long they've had pain and what they've been doing for it is really helpful.
Right.
But you're not going to, pain is miserable, but you're not going to miss pain. So you want to make sure you're not missing acute chest, right? Fever, any of the bad things. So having a systematic way that you evaluate somebody is what's most important. Checking to make sure their hemoglobin's at baseline, their platelets are not low. A lot of our patients, right, have high white counts at baseline, but making sure their white count isn't 30,000 or something out of control. So those are the things you can do to help keep people safe while you're working to treat their pain. We do take some patients who are on Suboxone and actually put them on IV Dilaudid if they're having a crisis. That was not this young man's case. In his case, he wasn't taking the medicine the way he was supposed to. So he was a little bit different. But there are a few patients who are definitely, and they get some IV Dilaudid and then they wait 4 hours and restart their Suboxone and they're okay. And that's all right. We do that sometimes.
Thank you, Dr. Kanter.
So, and part of that is also that if they're really having a crisis, remember that Suboxone and buprenorphine are slow activators, so they just don't work right away. And so that's one of the reasons that some people will say, no, I really need, IV Dilaudid. But a lot of it has to do with whether we're controlling or not controlling their sickle cell.
Thank you, Doctor.
You're welcome. Other questions?
Oh, you know me, I have to comment. I will say that Dr. Gore did a really good job with this patient and actually did discharge him without the words AMA anywhere in the discharge summary. So we
good.
did appropriately discharge him. So that's what I always say is no one leaves AMA on my service.
No, that is fantastic. And again, I talked to you the whole way through and I thought you did everything right as well. Again, it is hard. It is also hard. We didn't get into the business of medicine to not help people feel better. And so it is really hard to be the bad guy, for lack of a better way to put it. So, but sometimes you have to recognize that you're still in it for the greater good that, our patients can't see. Right. It's no different than my 14-year-old who's like, no, I can drink a Coke at 8 o'clock at night. I'll be fine. No, right. Like that's not good for you. You may want it, but I'm not going to give into that. And a lot of that is the same. And but I really try to avoid, I do think your first patient has obviously polysubstance addiction. Mr. Jackson does not. He is not what I would call an addict for a number of reasons. I would say he is absolutely opiate dependent. His body is used to taking these medicines, has been for a long time. And he has, the reason I like the term opiate use disorder is he has an unhealthy relationship with opioids. It's a little different to me than someone who's taking street drugs. My friend Pat, who I'm going to get to come talk to you guys, Pat Carroll, he would tell you it doesn't matter and he doesn't care what you call it. It's just how we respond to it that matters. But I think that what we're trying to do with him is a little different than you have with your situation with your young lady. So you did a great job.
Thank you so much.
Any other questions? See, only in the sickle cell world, you get to learn all about pain management and opiate management, which is, one of the many benefits, and really looking at socioeconomics as well. All right. Well, great job. Thank you for 2 tough and interesting cases. And we will definitely be back in 2 weeks. So let us know if you have any other cases in the interim. And I am going to look for a time that Dr. Carroll can come give his awesome talk, because I think it'll really help clarify some things. So we'll look for a time he can do that too. And I'll connect you to him, Sonia.
Thank you.
We may have some folks coming in the next couple of months from joining us from USA, from their residency program. I spent some time down there this week, and they have, different but similar sort of issues. And so I think it'll be great to get some opinions. So just to make sure we recognize that there could be people from other institutions. So to make sure that we're not using HIPAA information will be really important. Awesome. Well, thanks, guys. Have a happy Tuesday.